And here we go. So my name is Jenna Strusand. I'm the program director at the Breast Health Collaborative of Texas, and I'm very excited to welcome y'all to the very first webinar of 2017. We got to have a bonus webinar this month. I know today's not Thursday, but we can pretend. So I am happy to welcome Sharon Feltz and Dr. Rakhshanda Rahman. They are here to present establishing a community outreach program for breast health awareness. Sharon Feltz is the outreach and grant manager at Texas Tech University Health Sciences Center, Breast Center of Excellence in Amarillo. She's the liaison between the university and the community. As a breast cancer survivor, she has a unique perspective as the master trainer for coping skills for patients. She's a certified patient navigator and a relentless advocate for survivors' quality of life. Dr. Rahman is the director of the Texas Tech University Health Sciences Center, Breast Center of Excellence in Amarillo, and professor of surgical oncology. She has over 20 years of training and clinical experience in comprehensive breast health, ranging from benign conditions, risk assessment, cancer prevention, and breast cancer management. She continues to contribute to clinical translational research and training of future specialists. Welcome everybody. I see that there's an echo. I would suggest either only listening on your computer or only listening on your phone. We have both available, so you can choose whatever you would prefer, but I would suggest turning one of them off and deciding. All right, so I'm going to send it over to Sharon and Dr. Rahman.
Well, good afternoon almost. Hello, everybody.
Everyone else is on mute.
Okay, so Jenna, are you going to move the slides forward for us?
I would suggest that y'all do it so you can go at your own speed.
Okay, gotcha. Okay, so basically, the ABC for W
stands for our original project, which was Access to Breast Care for West Texas. And this is a replication model that our current grant is. So basically, we had this project since 2010, and we are now in the last year of a refunding project. So long story short, the first 3 years we were doing breast health work in terms of mammograms and education pertaining to breast health, and in our reapplication we actually added cervical cancer, which used some of the same principles, um, which led us to believe that this is a very replicatable model. So here on out, when I talk about it, I'm going to focus on breasts. The focus is not cervix, but I wanted to make a point that the principles we are going to talk about are actually replicable and scalable to any model that one may wish to use. So the objectives for our next about an hour together is that we'll review the essentials of building a community collaborative, and this really is a bird's eye view. We're not going to really delve into the details because that would probably be covered in some of our subsequent seminars, but this is more like a teaser that gives a perspective. Um, then we won't actually conduct, we will share with you the evidence-based strategic session, how to do it and what happened when we actually did it in real time, to just share those with you. And third is to identify key stakeholders and what's their role in a large community outreach grant proposal that could apply to whichever community that you represent. Okay, so this particular slide, if you look on your left, that's really our dashboard um, over about 6 years of our grant funding. What were we able to do? So you can tell that based on the model we're about to discuss, we were able to make about 1.6 million indirect contacts. We were able to personally reach 18,000 people, mostly women because it's a women-focused program, and we were able to perform about 5,000 mammogram services. 1,000 of them were abnormal. We found 58 cancers, and each one of them got great treatment. On the right side, you would see that all this dashboard resulted from the innermost tiny circle. And our goal is to reach all of you to see if this method works for other people and they can replicate that model. And of course, all these bigger circles are our partners, such as the Breast Health Collaborative, that's going to help us reach other people. So our model basically includes the very important, we think, is a partnership between public organizations, private organizations, and community. Now you hear a lot about public-private partnership. That word gets thrown out a lot, but you'll see that community is missing from that. And if your end user of your education or mammogram service, whatever you're providing, is the community, then that has to be at the table as a main stakeholder, which I believe is a big reason of success for our program. So in our system, the public organization was represented by the Texas Tech University Health Sciences Center Breast Center of Excellence. We have a large community collaborative organization, which is represented by Amarillo Area Breast Health Coalition. They have changed their name now to Panhandle Breast Health. And we have several private organizations which happen to be different hospitals and mammogram service providers, which tend to be the for-profit piece of the puzzle. So I'm going to first talk about what the role of public organization is, and then Sharon will take over
for the community organization, and then I'll pass it back to you.
So we'll just do a little bit of a tag team here, okay? So from the public organization standpoint, what could we do and what did we do? First off is obviously the needs assessment. Whichever community you're in, if you're writing a grant proposal, the reviewers want to see not only that you have a handle on the needs of your community, but you're actually are not using this global data, but you're actually involved with your community enough to to carry out the strategies to address those needs. That's an important component. So our assessment reflected that 54% of our people were uninsured. Now that's seemingly a high number, because if you look at literature, generally a nation data will say something about 35% population, not patients, population will report as uninsured. In our area, the community needs assessment, which came after this figure, reported 25% self-reporting uninsured. The 54% that I put on the slide is from our patient population that actually was treated in the clinic. 54% were uninsured. So that already tells you the off balance and the needs right there. And of course, 15% at that time were showing up with advanced cancers, advanced being defined as stage 3 or 4. Then we know, now this is more generalizable data in Texas, that 1 in 3 physicians are not recommending mammograms to eligible women. And by the way, this is when the screening guidelines were not confused. When everybody knew that 40 and older people should get mammogram, even then the recommendation rate was low. I can only imagine that it's probably worse now because there's a lot of confusion about screening guidelines. 50% of our patient population represented minorities, and all the providers are for-profit organizations, so they don't have a portfolio of providing care to unfunded population. Now, we did write this grant, and at that time it was called a Community Collaborative RFA. That RFA doesn't exist anymore. To enhance the awareness and knowledge regarding breast health, so there was a knowledge component to our grant. Increasing breast screening, which probably all of us have that goal, and lower the rate of late-stage diagnosis. And we got funded for $1.6 million in 2010 based on that grant proposal. Now our strategies were to actually identify resources within the community as collaborative partners. Sometimes the issue is that we don't completely capitalize our resources within the communities, and those resources can be immensely valuable in a large collaborative. So, and more importantly, as a public organization, so you have the funding, you have a grant, and you have the infrastructure to manage a state funding, but it's very important, why should another organization be your partner? What's in it for them? So we have to identify the needs of the partners that we can address that they may not be able to address. So for example, a for-profit organization of course wants to get paid for a mammogram service. That's what they are there for. On the other hand, they don't have access to grants because grants are applicable only for not-for-profit organizations. So you have to come up with a collaborative win-win agreements. Financial assistance, we could provide clinical expertise backup if you have rural clinics, small clinics, or areas where physicians are not available, community volunteers are working. They are very uncomfortable advising women. If a woman walks up to a volunteer and says, I have a breast lump, imagine the discomfort of right or wrong advice that this person is going to give you if they don't have a backup of somebody who's teaching them evidence-based stuff, or in cases of confusions, they can pick up the phone and call somebody to help this person out, because nobody wants to be held responsible for something bad happening to another person. And of course, curriculum development is a forte of a teaching institute. So that's what we brought to the table. Now, when we started that, everything looked very good on paper, but when we looked at that a few years later, overall, we felt great because we reached about 9,000 women, we educated about 1,400 people, we provided 245 services, found 7 cancers. We felt pretty good. But as we evaluated our program, we realized that there were some issues. For example, every now and then, not very frequently, but I got some mammogram reports on 20-year-old girls who did not need a mammogram because you have this contract with your partner. Somebody calls them, my breast hurts or I have a lump, and they schedule a mammogram because they're your partners. They know that even though the patient's unfunded, they can send you a bill. So we realized that of course we got to fix the problem of unindicated services. Then of course billing issues were there because many organizations these days have their billing offices maybe in another state. We have 2 or 3 providers whose billing offices, one of them is in Kentucky, one of them is in California. So in our original discussions, we are talking to hospital CEOs and radiologists and mammogram techs, and the people sending us the bill actually have no idea what the program is. And the third problem was that there was perceived competition. If I have contract with 2 different providers, the one provider doesn't want me to have the contract with the other providers because it's a business competition for them. So those issues we had to address. So we discussed those hits and misses with partners. We retweaked some process map, and this is what I meant by that we're not going to go deep into it. I mean, developing process map is a whole detailed discussion that how did we address accountability, guidelines, indications, which bills to be paid, how to be built, and all those type of things. We identified efforts that different people were doing the same thing over and over, how to minimize that. We introduced some systems of accountability and customer service concept. So not only the patient that we are performing the mammogram on is a customer, but we are each other's customers. If you're my partner, then I'm your customer, and as a part of customer service, you need to send me the correct bill and on time. And I am your customer because I need to respect your time and scheduling issues if I'm booking mammograms, things like that. So main lesson learned was communication, communication, communication. We are all on speed dials with each other, um, you know, Facebook, phone, email, text, whatever it takes. We continually talk and do the troubleshoot as we go. And we were quite successful at obtaining the STAR program status by CPRIT um, in that time, and we developed some creative solutions and product lines. This webinar is a result of that product line that CPRIT felt that we have something to offer that other people can replicate. And leveraging success for further grants, letter refunded in our second cycle for about $1.5 million and dissemination grant as we speak. Some other strengths of a public organization is, of course, you have public organizations, 501c3 status. That has a lot of access to different things that for-profit organizations may not have. We have office of sponsored program. Working with state funds is a very, very bureaucratic process, and for smaller organizations that may be very difficult. So that's what we bring to the table. And ready access to new evidence, because obviously as an academic institution we are constantly updating our curriculum slides and evidence base and what have you. And basically a large institution provides credibility to smaller organizations in the community, which often don't get funded because one of the actually headings you have to address in your grant application is organizational capacity, that you're actually dealing with a lot of money, you have people who have fiscal management training and all those sort of things, and a big organization like a university does bring that to the table, even though money is accessible to smaller organizations. So, however, our weakness becomes that I cannot cancel my clinics and be at the community event all the time to reach these women, because our time commitment from clinical job duties cannot be canceled. So it is important for us to have a community partner that can do that for us. Plus, people who are most in needs are least comfortable navigating the system. If any one of you have ever tried to make an appointment at Texas Tech, you know what I'm talking about. So that's our weakness. I mean, big organizations also have big problems. Bureaucratic systems sometimes may impede the progress, which small organizations make a couple phone calls and the problem's taken care of. So those are the downsides. Hiring is not easy. You have to go through tons of systems, especially as a state organization's contracting and payment processes. So now I'll hand over to Sharon so she can represent, although she's Texas Tech, but she's going to speak on behalf of the community organization.
Okay, so I'm going to speak to you about the community organization, which was a real critical key to our success. Amarillo Area Breast Health Coalition, and as Dr. Rahman just stated, is now Panhandle Breast Health. Their mission is making breast health happen in the Texas Panhandle. So that was a perfect partner for us as far as the coalition goes. So I want to speak to you specifically about one of the ways that they do make breast health happen in the Panhandle. They have a program that's called the Wise Woman Program, and that stands for Women Inspiring, Serving, and Educating. And this program's been in existence since 2009, and this was exciting for me because at that time I actually worked at Panhandle Breast Health and was part of the planning team that put together this program. So the primary goal of the Wise Woman program was to teach, support, and empower women with information about breast health. And it specifically targeted the underserved, low-income, diverse populations and helping women navigate those that were eligible for no-cost screening. So you can see what a perfect marriage this was, because our grant was an outreach grant and also provided services. So having them as part of that program was really key to our success, especially in that outreach and education part. And then the secondary goal of the Wise Woman program was to grow a network of community partners that contribute services and resources. And this also aligned perfectly with what we were trying to accomplish with that first grant. So looking then at the strategies, the Wise Woman program and Panhandle Breast Health took a look at, okay, we need to recruit and train volunteers so that we can launch this program and increase awareness and the knowledge within our community. And then this was going to require providing trainers and resource contacts throughout the year. And Dr. Rahman put together evidence-based information to the women within their communities. And then they also had advisory communities within their different small towns that could help identify women who would be good, wise women. So as you can see, this partnership would just continue to grow. So the secondary goal then was just for them to continue that communication with their partners, and then also make sure that they could minimize duplication. And then the Wise Woman program also has its own internal and external accountability processes. And then there is a constant evaluation and reevaluation that's going on. So how the Wise Woman program got started is that initially they offered an incentive for volunteerism because they worked with different apartment complexes that actually supported this program by giving incentives to one woman in each of the apartment complexes that signed on to be a wise woman. At first, the curriculum was informal, and there was a shift in what Panhandle Breast Health was doing, in that it was originally most of the women that they were reaching were older women and they were Caucasian. But they knew that there was a great need to reach out to individuals of different diverse populations. And so one of the first things that happened as part of their journey was that they formalized that curriculum that Dr. Rahman helped with in putting together a curriculum that was really a curriculum at like the 3rd to 5th grade level, because we had a very diverse group of wise women that ranged in age from 21 to 68. And the curriculum goes through periodic re-education, and the information is updated based on evidence-based information as well, because we wanted to make sure that that was accurate. So where the Wise Woman program is now is that they have 20 volunteer trainers. Different people help with the training. There is much more diversity. If you look at the slide, you can see that it's the people who are part of this program are no longer primarily white, and then the people that they are educating has become much more diverse as well. And so within that first grant that we had, and Dr. Rahman, feel free to jump in.
Okay. Because I just wanted to say that Sharon was bragging that we made the curriculum, but one of the important things that Sharon herself trains the wise women is not just teaching them about breast health, but actually how to create and do an event successfully in a community. So there is some expertise as to team building training and communicating, talking to difficult situations, difficult circumstances, and communication. So that in itself is a training that Sharon has some expertise in, and I think she missed mentioning that, so I was trying to remind her to say that.
Okay, thank you very much. So I come from a background in hospitality, so customer service is very important to me, and there's a lot of specific techniques that can be used for customer service training. And then also too, I have a background in training, so we teach also the wise women how to connect with individuals one-on-one, and actually how to pull together an outreach event where they're going to be giving a presentation. Dr. Rahman is sitting here nodding at me like, yes, tell them that, tell them that. So that is definitely part of that Wise Woman program, because we want to send wise women out into the community so that they feel confident in talking to women, and that makes a big difference. Okay, so the Wise Woman program strength is it gives the wise women, Panhandle Breast Health, and then also Texas Tech, it gives us direct access to communities and information from the grassroots about the level of awareness, what are the barriers that are going on within that community that we're going to have to overcome. And then also too, volunteerism allows uh, a time commitment to the community without a financial conflict of interest commitment. So Wise Women are Switzerland.
Correct.
Yes. So our weaknesses of the Wise Woman program would be for Panhandle Breast Health, a lack of resources. Sometimes they don't have direct access to evidence-based guidelines, and that's where we can help out as Texas Tech. The access to clinical expertise. We're on speed dial with Panhandle Breast Health. And then we also can help with financial constraints with that community organization because we contract with Panhandle Breast Health.
Yeah, like if they were on their own, they really, I mean, largely they function off of volunteerism and people's heart. And so there's just so much you can do without money. So this allows for a good partnership where we can provide the funding, but I can't cancel my clinic. So, but I can provide them the funding so they can go in the community and do the job.
And then sometimes volunteerism can be difficult to hold accountable. So I'm going to turn the microphone back over to Dr. Rahman to talk about one of the private organizations that we work with.
Right. So we actually have several contracts with the different radiologists, but I just use the one big partner as an example. Um, so, which is the Northwest Women's Imaging Center, and I'm going to talk on behalf of Shelley Price because she's, as usual, busy at her for-profit organization who won't let her go. So basically, they are our partners in the Breast Center of Excellence anyway. So their mission is to deliver highest quality of care to the community, and they provide screening services to make early detection and diagnosis of health problems. Earlier breast cancer disease or other problems are detected, the better chances on successful treatment. So you can see that how all these missions are well aligned with each other, and that's why they're easy to leverage. Now, they provide digital mammography, ultrasound, MRI, bone density, Faxotron, and on-site scheduling registration. But you can tell all of that happens once you enter the building. So their partnership with the university um, was very helpful in both ways. First of all, Northwest actually does have a special commitment to the indigent care anyway. They're contracted with the city. So now that is unique to this partner. Not all our partners have that. So they actually fund every 3 years a community needs assessment project, which is often, at least twice I remember, has been conducted by North Texas University because they do a lot of epidemiological work, which, as I said, is helpful in your grant writing or developing a proposal to get to know the needs of your community. And of course, they provide financial support for the university's, teaching, residence, and patient care programs. And they receive funding, like I mentioned, from the city contract to take care of indigent population. So their strategy was that because it's a for-profit hospital, they cannot write the grant, but we can subcontract with them. So we have a contractual agreement for screening and diagnostic services at Medicare reimbursement rate. Typical grants will allow you to pay Medicare reimbursement rates. Then there is a system for release of reports to the program directors. So we had to make it a part that every woman that is served by our partner, I need to be able to access their mammogram report because the last thing you want to do is miss on somebody whose mammogram was abnormal and nobody followed up on. And of course, then we had a lot of learning curve to how the billing is going to be happening because bill comes from California. So they needed to make sure that the verbiage, the name, some organization have slightly different names on their different letterheads. So obviously, if the name doesn't exactly match with the contract, you can't pay the bill and those type of things. So now, when we went about executing this program, the program office, which means our office, the main granting agencies, um, qualified the women, and because it was important, because we had very strict definition of financial criteria of what qualifies as, poor women. So unfunded, in our case, it was people without insurance up to 400% of poverty line. Um, the reason we did that on purpose was 200% and below qualifies for BCCS funding in most places. So we wanted to get this working poor class or people who make a little bit more money than to qualify for Medicaid, because those are the people who fall through cracks. And by the way, that definition was basically definition that I came up with, and CPRIT happened to agree with it. That doesn't mean CPRIT told me to do that. So you can be creative as long as you can justify why you came up with what you came up with. Then the program staff actually, we tried to see these women at appointments. Initially, our person from the office would run to the hospital to meet this woman when she's getting a mammogram, to get some paperwork done, because we may have talked to this woman over the phone. So this was our first meeting, and we had to prove in the CPRIT situation, particularly that this woman is a Texas resident. And as you can see, we're geographically located where we get a lot of patients from Oklahoma and New Mexico, and we cannot use CPRIT funds for those. So we needed to collect some evidence that they live in Texas and that they're poor, and their name actually matches, because in some communities they have lots of different last names, and the last thing you want to do is treat a wrong person. So we collect those documents. Reimbursement of services, of course, depended on receipt of invoice, and provider performed mammograms if they ran into unfunded women, but they sometimes performed the service and then informed the program and sent us an invoice, which you can tell that that could sometimes lead to a problem. So what happened with them is that they provided services, which was good for them, about 246 women that they provided services to that they would not have reached without the program. They were able to accommodate symptomatic women for diagnostic workup on the same day, because they knew that there is a backup funding available. And if these women were found to have cancers, because they themselves are indigent care provider for the city, many times they were able to directly plug them into the system for cancer care. So that was good. However, again, the unindicated services happened sometimes, which was a miss, and there were billing issues. If they went ahead and did somebody's mammogram and send me a bill and I have no idea who this woman is, and doesn't meet our criteria, then in retrospect you have to, that that gives rise to some bad blood sometimes if you don't have upfront good communication. And of course, the competition piece is always there for for-profit people. So we had several meetings. We discussed hits and misses and explored solution together, and talked about what would be the best way to move on. And then we realized the technical and the professional services agreement. Many for-profit organizations have, the hospital will have the mammogram unit, but they contract with the radiologist group to read, which, much to my surprise, I had a contract with the hospital but not with the radiology group. So I would like for other people to know, to think about those things, because you may get, for example, our contract said Northwest Texas Hospital. The invoice said Rad Care. Now I can't pay that invoice because my computer system at Tech doesn't know who Red Care is. So those are just little logistics issues that we had to address. And then we negotiated for some best processes for a smooth execution of the program. We not purchased, but had blocked appointment with them, so that if we are out in the event, instead of having to pick up the phone and call and make the appointment, I already have sham appointments, about 10 appointments in my pocket that I could give out to the patients as when we are sitting there. And we realized that we don't have to travel to the hospital to get the document collection. We could say, well, you're a for-profit organization, you're actually making money, please collect the documents, because if you don't collect and fax these documents, we may not be able to pay the bill. And that is a very good incentive. Money is a very good incentive for many things. So that created accountability, and then we made payment arrangements with the radiologists who were not in the system. Moving on, with all those solutions that we put in place actually the business share by this particular hospital, you won't believe, for all the mammograms they do, 85% of them are grant funded mammograms. That's a big business share for them. So we developed some creative solutions. We developed this 1, 2, 3 process at an outreach event where the Panhandle Health will sit there on table one. They will do the education. We will sit at table two. We will get the financial qualifications done. And mammogram provider, depending whoever is close in that event area, will be at table three giving out appointments. Since women will leave with the appointment in their hand, we brought down our no-show rate from 47% to 14%. And we actually presented that video at a secret conference. Partnerships allowed for negotiation of a nurse navigator because we had so many patients that we said, you know what, you guys need a navigator to do this, which is good service for any, which was not grant funded, but it was good patient care, and we were able to motivate the hospital to fund that position. So at the end of 2016, the grant funded services were 1,000 plus by just this one provider. So that I think was the important part. So the strength of a for-profit organization is they have all the complement of services. I mean, the mammogram equipments and things, they're costly equipments. They have a portfolio of community outreach. Any hospital that wants to have a good reputation in the community has a community outreach component. They are able to explore indigent care programs. Often big hospitals will have a social services department to help poor people, because especially if they have an emergency room, they can't say no to these people, so they have resources available to help with funding. And they are usually close to the service, so we have about 8 or 9 contracts throughout the Panhandle area in different cities, so the women don't have to travel too far. And of course, being a partner, they can solicit advice relatively quickly. The weakness, as I mentioned, is being for-profit allows them not to access some of the funds available. The subcontracts with radiology groups sometimes limit certain endeavors because everybody has their different mission and goals. And location of the billing departments in another state was not very helpful, so that was a difficult situation. And then sometimes it's always an issue to be able to offer a service which is not covered by the grant. Like, for example, if you find cancer now, the hospital offers surgery, but somebody has to come up with solutions to who will pay for it. So that comes to this slide actually just has our contact numbers and emails if you had any questions about or any help that we could provide. And back to Sharon.
All right, I want to spend about the next 10 minutes or so with you, quickly taking you through a strategic planning tool that we have used several times that can be the initial step to establishing a community outreach program and submitting a grant proposal. We actually used this tool back on November 7th at a program that we did in Lubbock, Texas, and we had 3 different teams from Abilene and the Permian Basin and Lubbock that were interested in writing their own grant to establish an outreach program. So I'm going to give you information on how you can use this tool yourself if you're thinking about moving forward with such a program. And the name of the program is called the Six Thinking Hats. And I was introduced to this program many years ago when I worked at Opryland Hotel. And the program was done by Dr. Edward DeBono. And I think it's about 30 years old. And there is actually a book that you can still go online at Amazon and present.
And a website. They have a website.
And a website as well. And so the 6 thinking hats represent 6 different modes of thinking. And I'm going to take you through those and then also to how you could use this as your strategic planning program. But one of the main points of the 6 thinking hats is that if you're using different modes of thinking, that it can also help you look at a project project from different perspectives. And it can help us make better decisions by forcing us to think outside our habitual ways of thinking, which can, can sometimes be a barrier to that creative process. It can help us understand the full complexity of a decision that we're looking at or a proposal that we're looking at. And it can help us spot issues and opportunities. So the key point um, to using the six thinking hats is that everyone is going to be wearing the same hat or using the same mode of thinking at the same time. So I want you to picture this. I want you to think about a meeting that you've attended, let's say, in the last 6 months. And it could be a work team, a volunteer team, or you could even be on a board. And have there ever been times when the team is discussing and everybody is all over the map? And you're looking at a proposal and some people are saying that it is a great idea, that this tops even the best thing since sliced bread. And then you'll have other people in the group that are going, no, no, this would be the worst possible solution ever suggested. And then you have other people going off in other directions, and some of them are just sitting there and they look like they're completely removed from the whole thing. And even worse, you've got someone in the group who was the loudest, the most persistent, and just wore everybody down and got their way, even when the group knew it wasn't the best solution. But you're so tired of going in circles and trying to keep up with the discussion. And you're sitting there and you're thinking, I'm losing hours of my life I will never get back. And I know I've had to sit in some of those meetings. I've had to sit in some of those meetings as the person taking minutes and then trying to make sense out of the discussion. The great thing about the six thinking hats is it's going to provide direction for thinking, and it's not going to label thinking. And it's going to allow everybody on the team to contribute under every hat, even though they may even support something that's opposite than the one that's under consideration. So we say, why hats? Well, hats signify roles in life. They're easily put on or taken off, and usually we wear a hat one at a time. So the hats work because it's going to provide structure. You're going to do one direction of thinking at a time. It allows for total thinking. You can use it in multiple ways, in groups, alone, two people having a conversation. I got a phone call from Dr. Rahman over the weekend telling me I'm doing six thinking hats for our application right now, and I'm already identifying the different things that I'm going to need from you that I hadn't thought about, just because she was doing that really focused thinking. So there's a lot of great ways that it can be used to help you out. So we finally get to tell you what each way of thinking each of these hats represent. So the white hat, we're just going to be talking about information. Information I have and information that I need. The yellow hat will be the logical positive. The black hat would be those cautions or barriers that we need to think about. The red hat is intuition, feelings, and emotions. The green hat is creativity and alternatives. And the blue hat is really the person who's managing or facilitating the process. Now, a lot of people use SWOT analysis, and I really like this more than a SWOT analysis because it gives you those opportunities to focus on that information you need and that information that you have. And there's also a place for people to express their feelings and
SWOT,
emotions.
SWOT doesn't have gut feeling.
Right. So, and the feelings are going to be there whether we acknowledge them or not. So why not get them out, acknowledge them, and you'll know where people stand when you're taking a look at a proposal. So when we looked at this back in November, the purpose of that meeting was to establish a community outreach program for breast health awareness and screening. And each team were meeting as a separate unit as we went through this because it's three different communities with different needs. So the process that you would be using if you were to take advantage of this strategic planning process is that you would introduce one hat at a time, that you would then brainstorm responses, and you would record those responses on a flip chart page, and you would go in order, and if someone didn't have a comment to make, they would just say pass, okay? And then you would have a facilitator who would be keeping everything on track. And it was an interesting process for us because we actually had three different teams that were reporting out at the same time, which I thought worked very well too because they were able to learn something from the other two teams that were there with them. So the blue hat person, as I said, is like the managing person, and they look at the thinking about the subject, they're constantly defining focus, and they're controlling the other hats. And they're keeping everybody on contract, on track. So if we're doing white hat information and we're just focusing on facts, and someone says, I just don't think this will work because, and so they're going to be giving a barrier, then the blue hat person would be the person saying, make a note of that. We'll be talking about that in a few minutes, and we'll make sure that we parking it, yes, parking it until we can get to it. So think of it this way. The facilitator is going to be the process expert, and the people there on the team are the content experts, okay? So an example of blue hat managing the process might be the facilitator saying, okay, what are some conclusions that we can draw from this discussion? So that will move the discussion along. The white hat is the information hat. And we're looking at information that we know to be true, and then what are some of the gaps in knowledge or the information that we need? It's neutral and objective. We don't make any interpretations or opinions. So here's an example of white hat. Communities of public health region 1 are primarily rural and constitute some of the most medically underserved areas in the country. Okay? And then information we need. When was the most recent community assessment of breast health screening rates done? So this is information that we would want to find out. So if you're writing a grant, think about it. This would be in an RFA where maybe you're asked to give the background of your community or provide statistics or provide budget information. This is all factual information. The yellow hat is the logical positive. And this is where we're looking at positive and constructive comments, but they have to be logical. It's like if we do this, then this positive outcome could be realized. Now it's not outrageous. It must be based on logic. Okay? An example of something not based on logic would be, I bought a lottery ticket. I know I'm going to win, but I don't want to wait until Wednesday to find out if I did win, so I'm going shopping tonight for furniture. It's not logical, okay? It looks forward to results, and it finds value in what's happened. So an example of a logical positive is a program like this can increase overall breast health screening rates in our community. That is a logical response for being successful in this. The yellow hat, the black hat is the caution hat. And the caution hat.
That's the hat everybody wants to talk about.
Yes, everybody wants to talk about this first because we can tell you all the reasons why something will not work. And that's why I like to do the yellow hat first and the information hat first. And so probably if you're being the facilitator, this is the hat that people will bring up that you're going to have to refocus then you're asking, how are you going to overcome them? So it's a very good idea to, this black hat has great value too, because identifying barriers can be critical to the process of developing what your project plan is going to be. Now, black hat is not an argument, but it must be an objective attempt to put the negative elements out there. You're not concerned with problem solving at this point. You're just pointing out the problems so they can be addressed at a later time. So it's valuable because it can save you time and a lot of embarrassment too, if you haven't thought about this. So the green hat is the creative hat, and this is one of my favorite hats to wear because it's new ideas, it's creative alternatives, it reduces judgment, there's no criticism of these new ideas. And one of the things that I really stress when I'm facilitating a group is it's very important for both the listeners and the thinkers to both be wearing that green hat at the same time, okay? Because we want to do this without judgment, okay? So green hat thinking can help you identify really some of those strategies that you're going to need to overcome those barriers that you've identified when you were wearing your black hat, okay? And it can also be used to help you come up with new strategies for supporting the benefits and the positives behind what you're going to be able to um, do with your community outreach program. So the red hat, those feelings, this is the touchy-feely part, okay? And this can fit in any time, during any time when you're using the six hats process. You can use it early on when you've got the group together just to get a temperature check on how everybody's feeling about this, because you don't want these feelings lurking in the background. And emotions do affect thinking. So give people the opportunity to get that out. You can use it as a way to identify initial perceptions and just get them out on the table. You can use this hat after a proposal has been outlined to say, okay, as a facilitator, this is how it looked like we were feeling at the beginning of this process. May I ask the question now? What are you feeling? The most difficult part of wearing a red hat is you have to resist the urge to justify or explain why you feel the way you do. So we're not going to do that. It's just, this is how
This
I
is
feel.
where you're allowed to be completely illogical.
Yes, absolutely. It's the opposite of neutral and objective. So an example might be, this will require a lot of work. I'm not sure I can do it. Or someone else may say, I'm really excited about the difference we can make with this. And it's not, I'm excited about the difference of we can make because. You just stop at that point. And then always you have that blue hat person who is wrapping things up and helping provide that action plan to move forward. Because you can take a look at, what you've documented, and it's going to tell you this is the additional information that we need. It's going to tell you these are the positives we really want to maximize, or these are the cautions or barriers that we need to address as we put this proposal
And
together.
when you address all of those in your grant, the reviewer can tell that you've thought these things through. And I think it affects the positive score on your grant to get funded.
Yes. And are there creative ideas that we could take and incorporate this into our program? As Dr. Rahman said, we're currently working on writing our third grant. And so this was an opportunity to say, okay, here are some creative strategies that we've not used before, but we need to incorporate them into this program because the information that we've gathered from doing this for 6 years shows us where our weak points are and where our strong points are. And then the resources available. And then, who's responsible for what, by when. That's definitely wearing the blue hat so that you can move the that's all that I have. Dr. Rahman, do you have any?
Sharon and Dr. Rahman for presenting. We will have them back in April, so they can share further. Thank you, everybody.